So, in our last video, we had just gotten started with reproductive pathology. We looked at a bunch of stuff. It was quite a handful of random things, but most importantly, we needed to make sure we knew the difference between the female hormone system, as far as the reproductive parts are involved, and the male hormone control, right? So there's an analogy between the two sets, right? You have the LH influenced theca cells in females and LH influenced Leydig cells in males. Those two guys are pretty similar to each other. And then the FSH influenced granulosa cells in females and FSH influenced Sertoli cells in males. And there was the whole concept of aromatase and deficiencies of that, right? We talked about Klinefelter, Turner. We looked at the main things that can occur where you can have other things outside of Klinefelter and Turner besides congenital adrenal hyperplasias. We had the aromatase deficiency, androgen insensitivity, 5-alpha-reductase deficiency, or common syndrome where you don't even release GnRH. So there's no FSH, LH, anything, right? All of these are different scenarios that you can get, and each scenario is very unique from each other, right? Different from each other. They're unique, and we also had to compare them to something we saw earlier, where you got to see Müllerian agenesis and the deficiency of alpha reductase, right? We saw also the deficiency of Sertoli cells, all those things that occurred earlier in the reproductive chapter. So now after all this, we're finally down to looking at a bunch of practice questions, right? So these are the newer additions. These are not in the older reproductive videos from the First Aid 2018 book. So these are a bunch of AMBOSS questions. So let's take a look, because some of these were ridiculously hard, but not necessarily actually hard. Like, I was confused. For example, this first one right here, you can see only 19% of people got it right, and I was very confused that that occurred because there was no reason to pick anything else, but you can see choice C where everything is normal. So let's take a look. And I love this question because it's very typical of such a thing. So 15-year-old girl comes to the physician with her father for evaluation of short stature. As soon as you see a 15-year-old girl that's considerably shorter than she should be, like you don't bring your daughter in unless she's way too short, right? You think of Turner. Now, she feels well overall, but is concerned because all of her friends are taller than her. Her birth weight was normal. Menarche has not yet occurred, which is very concerning, right? She's 15. She hasn't had her first period yet. Her father says he also has short stature and late puberty. The girl is at the 5th percentile for height, which is ridiculously low, and 35th percentile for weight. Breast development is Tanner stage 2. Pubic and axillary hair is absent, which is a huge point right there. Right, that's actually a giveaway for the diagnosis. An x-ray of the left hand and wrist shows a bone age of 12 years, right? So that's significant, right? Because her actual age is 15, but her bone age says she's 12. Further evaluation of this patient is most likely to show which of the following sets of lab findings. And the answer here was everything would be normal. Why? What is actually wrong with her? Right? So this patient presents with delayed growth and pubertal development. Her skeletal age is less than her chronological age, which indicates constitutional growth delay. This hormone pattern is consistent with constitutional growth delay, the most common cause of delayed puberty. It is characterized by temporary delay in the pubertal growth spurt and development of secondary sexual characteristics. Patients classically have a bone age that is less than their chronicle age, which is the case here. A family history of delayed growth and puberty is often present, which the dad did say also. Although the onset of pulsatile GnRH secretion, which is necessary for puberty, is delayed, LH, FSH, and total GnRH, as well as estrogen levels, are typically normal. Okay, there was no reason to think it was anything pathological, but this question is very iconic because it does such a good job making you, practically forcing you into picking an answer choice that does not fit, right? Because you want something to be wrong and you want to be proud of yourself for knowing what was wrong. But all in all, there was nothing wrong. The only real issue that was wrong with this patient is just delayed puberty and delayed growth, which is, it's not the most common thing on earth. It's not that common to begin with, actually, but it can happen. It can definitely happen. 30% of people chose D, right? High FSH, high LH because you don't have a negative feedback, low estrogen, and high GnRH. This hormone pattern is consistent with hypergonadotropic hypogonadism, which is seen in Turner syndrome. Right? Remember, hypergonadotropic meant that you're releasing gonadotropic things like FSH and LH, And hypogonadism means that your gonad is not releasing anything, so no estrogen. And that's seen in Turner syndrome. A lack of serum estrogen results in loss of negative feedback to the hypothalamus and pituitary gland, resulting in increased secretion of GnRH, LH, and FSH, hence the hypergonadotropic part. Turner syndrome manifests with short stature, just like this patient, and incomplete pubertal development, which are seen in this patient. However, this patient lacks other typical features of Turner syndrome: lymphedema, shield chest, webbed neck, any cardiovascular thing like bicuspid aortic valves or coarctation of the aorta. She didn't have any of that, right? They didn't mention anything for you to think she might have any of that. And or urologic abnormalities, because remember they also have a horseshoe kidney, right? So none of that was given. So there was really no reason for you to think that this patient might be a Turner syndrome patient simply off the fact that she's 15 and doesn't have her period yet. Okay, that's all they really did there. But they didn't give you anything else. Her Tanner stage was okay. For age 15 to be at Tanner stage 2 is not that far-fetched. Remember in the last video, when we were the video where we finished off the last video for reproductive physiology, we talked about the Tanner stages, and I said that the Tanner stages are only significant when it's profoundly off, right? So if you're 15 but you're still Tanner stage 1, that's a little far off, right? That's problematic. That's definitely worth looking more into. Or if you're like, or the other way around, if you're like 8 and you're Tanner stage 4 already, right? That's really bad. That's like something's way too accelerated here. Needs to be checked. So this was a really interesting question. I wanted to make sure I put it here. They actually try really hard to confuse you, right? Because remember, when someone tells you pubic and axillary hair is absent, that's actually quite diagnostic of androgen insensitivity syndrome, right? Because there's scant axillary and pubic hair, right? However, that alone is not necessarily diagnostic, right? It's a huge giveaway for what could be the answer, but androgen insensitivity syndrome would be a normal appearing female that's actually male, right? Actually male, 46XY, but they are just insensitive to their own testosterone. So testosterone has no effect, right? And then it just ends up happening that the patient looks like a female. And these, I said in the last video that these questions about androgen insensitivity syndrome, as well as Müllerian agenesis, often tend to be quite funky questions, in the sense that the question will start off telling you that a patient came in with their daughter, but the patient is actually a male, right? So that kind of thing you want to make sure you're very careful of. Do not assume just because the question says, a mother came in with their daughter, that the daughter is actually XX, right? You don't know that. I mean, someone just sees their child as a daughter because they look like a daughter, but until you've looked at the chromosomes, you don't know if it's actually a daughter or a son, all right? It's a very important thing to watch out for right there. So that was a very unique type of question. Let's take a look at the next one over here. This one wasn't so bad. This is actually a pretty important one too. High yield topic. Otherwise healthy 16-year-old girl comes to the physician because she has not had a menstrual period. Examination shows normal breast development, so secondary sexual characteristics are okay. There is coarse pubic and axillary hair. Okay, so it's not androgen insensitivity syndrome. Pelvic exam shows a blind vaginal pouch. Ultrasonography shows normal ovaries, which means that she's definitely XX, and an atretic uterus. So the uterus didn't develop completely though. Which of the following is the most likely underlying cause of this patient's symptoms? Well, if everything's fine and the uteruses didn't develop, that's Müllerian agenesis. Very straightforward, right? Agenesis of the paramesonephric Müllerian duct. Müllerian agenesis results in an atretic uterus, cervix, and upper third of the vagina. Those things just don't end up forming. That's the external part. It won't form. Patients are asymptomatic until puberty, when they present with primary amenorrhea. Development of secondary sexual characteristics occurs normally because she has ovaries which are functioning, right? In comparison, patients with androgen insensitivity syndrome, which often looks just like Müllerian agenesis, patients with androgen insensitivity syndrome present with primary amenorrhea, a blind vaginal pouch, an absent uterus and ultrasound, same kind of stuff, normal breast development. However, patients would not have pubic hair, since the growth of pubic hair is dependent on androgens. Ultrasound would reveal undescended testes that are, the mainstay of androgen sensitivity syndrome. We talked about it yesterday. Not yesterday, in the video right before this, we talked about in these people, right, androgen sensitivity syndrome, that you can often find the testes in the labia majora. Okay, So that's something you want to watch out for. And the position of the testes is such a big deal too, right? Because in 504 reductase deficiency, both of these questions we saw inguinal testes, right? Testes that also just have not descended completely, right? Inguinal testes. So the testes have not reached the scrotum yet. Very important to keep that kind of stuff in mind. Little details, but those little details are enough to give away exactly what's happening. Okay. So this patient was the one with Müllerian agenesis. Now, if we go back and take a quick look at Müllerian agenesis, right here. No, earlier. Yeah, right here. So right here you can see Müllerian agenesis, right? They talk about it. Mayer-Rokitansky-Kuster-Hauser syndrome may present as primary amenorrhea in females with fully developed secondary sexual characteristics because they have ovaries. So it's a degeneration of this stuff, right? So of course the external things are okay halfway. The distal vagina is okay, but the other stuff is also part of the external. Proximal vagina is also going to fuse with this and give you the whole vagina, right? So the proximal vagina is not going to work, and then the internal things are completely missing: uterus, fallopian tubes, right? So that's pretty problematic. No Müllerian duct and Müllerian agenesis, right? So very important to make sure you're ready to catch such scenarios. Every single sentence in this question that we just did right now up here was relevant to what's the final diagnosis. Next one here, 23-year-old female comes to the office because of a 3-week history of vaginal discharge and itching despite cleaning her genitals with a vaginal douche. Her last menstrual period was 1 week ago. She is sexually active with her new boyfriend. She has an intrauterine device and does not use barrier protection. She was treated for a sore throat infection 1 month ago. Right? Now they're throwing in all kinds of information. So they're really trying to give you so much information that you start, kind of thinking too much. Speculum examination, now that's important, right? The speculum examination, physical exam, stuff like that, those are very significant. Shows erythema around the vaginal introitus and copious white discharge. Vaginal pH is 4.3 and a potassium hydroxide test shows a multiple pseudohyphae on microscopy. Which of the following is the strongest predisposing factor for this patient's condition? And they had a bunch of answer choices that all looked good. This is a UWorld question, right? So only the first one was AMBOSS. The rest of these are all UWorld related questions in this box, everything here. So what was the strongest predisposing factor for her to have this infection? And the answer was suppression of vaginal bacterial flora. Why? Systemic antibiotic treatment, like oral or IV, causes suppression of normal vaginal bacterial flora, which promotes C. albicans overgrowth. Antibiotics increase the incidence of symptomatic vulvovaginitis and vaginal colonization with C. albicans in asymptomatic patients. A normal vaginal pH, which is less than 4.5, and pseudohyphae on microscopic exam of a potassium hydroxide test confirms the diagnosis. The patient was likely treated with antibiotics for bacterial pharyngitis, right? So that's all you had to catch. They threw in a bunch of stuff into this question, but her treated, right? She was treated for a sore throat infection a month ago, which means that it wasn't just a viral infection that self-resolved. So you have to understand that she was taking something for the sore throat, and most likely that something was antibiotics. So those antibiotics, obviously, antibiotics can also cause diarrhea, right? Because you kill your normal gut flora. So in this case scenario, they're talking about killing your normal vaginal flora, right? And then that's why she has the infection. Other answer choices were not using barrier protection, the vaginal douching, right? All of that stuff. And of course, vaginal douching isn't exactly the best thing to do either. But all in all, her main and most significant, the strongest predisposing factor for her condition was the fact that she most likely had antibiotics. 23-year-old woman comes to the physician because of vaginal discharge for 3 days. So now I'm tying this in with vaginal discharges that are relevant to microbiology, right? Because you always want to make sure you go back and revise all your microbes, right? So at the bottom, I'm going to show you, excuse me, the microbes that we're talking about right now. So 23-year-old woman, vaginal discharge for 3 days. She has been sexually active with 3 male partners over the past year and uses condoms inconsistently. Her only medication is an oral contraceptive. Physical exam shows thin grayish white vaginal discharge, no erythema of the vaginal mucosa. pH of the discharge is 5.9, which is very high. Adding potassium hydroxide to amount containing vaginal discharge produces a fishy odor. Further evaluation of this patient's vaginal discharge is most likely to show which of the following findings, and the answer was that it would be a gram variable rod. If you did sketchy micro, you remember Gardnerella vaginalis, where the coloring of the walls is both purple and pink because it's gram variable. It can be gram positive or negative. And fishy odor with the potassium hydroxide stuff is also in that image. Now, other things you're supposed to remember from that image are the fact that there's a detective searching for clues because you're going to have clue cells, right? Gardnerella vaginalis is a pleomorphic gram variable rod that causes bacterial vaginosis, which is consistent with this patient's findings of a characteristic thin grayish-white vaginal discharge with a pH of more than 4.5 that has a fishy odor when KOH is added. All right, so that's your positive with amine test. The absence of vaginal pain or erythema further supports this diagnosis. Bacterial vaginosis typically develops when the pH of the vagina rises above 4.5, which allows Gardnerella vaginalis to multiply and results in the characteristic malodorous vaginal discharge. Predisposing factors include a shift in vaginal flora, such as douching, right? Because douching decreases lactobacillus. That maintains the vaginal pH between 3.8 and 4.5. The release of amines from increased bacterial degradation of proteins and or increased sexual activity, as the pH of semen is between 7.2 to 7.8. Right? All of these are different factors relevant to the other question we just did, right? Because she was also doing a bunch of things that are relevant to the same factors. But you got to keep in mind that what they told you about the bug is the most significant thing, and they told you the pH stuff, the KOH response, all of that. So it was a gram variable rod, Gardnerella vaginalis. Next question. 16-year-old girl is brought to the physician because she has not attained menarche. So we're back to the reproductive concept again. There is no personal or family history of serious illness. She's 165 centimeters, so 4 feet 11 inches tall. Pretty short, she's under 5 feet, and weighs 115 pounds with a normal BMI. Breast development is Tanner stage 4, which is appropriate for age 16, and pubic hair development is Tanner stage 1, which is very far behind. Pelvic exam shows a blind vaginal pouch. The patient is most likely to have which of the following karyotypes? And you see how this question ends? This is the funky type of shit I was talking about before, right? 46XY. That's her karyotype because it's actually a boy, okay? So you got to be very careful. Even though this question started by telling you that it's a 16-year-old girl, this title of being a girl was really just given by what you looked at, right? You look at a person and you can guess whether or not someone is a boy or a girl by looking at them. Right? Physical characteristics. But physical characteristics do not give away pathology. Right? Reproductive pathology at least. So 16-year-old girl is brought, but she has never had a period. Right? Very short. And almost no pubic hair. Because Tanner stage 1 is no pubic hair at all. Nothing. And that is the giveaway for androgen insensitivity syndrome. Right? The fact that they told you all of these things. No menarche and no pubic hair combined with a blind vaginal pouch or ambiguous genitalia is a giveaway for androgen insensitivity syndrome. This 16-year-old patient is actually a boy. Okay, patients with androgen insensitivity syndrome are karyotypically male 46XY. The Y chromosome results in the formation of the testes from the undifferentiated fetal gonad. However, the genital tubercle does not respond to testosterone in complete androgen insensitivity syndrome, and masculinization of external genitalia does not occur. The uterus and upper third of the vagina do not develop because the anti-Müllerian hormone secreted by the testes Sertoli cells causes Müllerian duct atresia, right, the Müllerian inhibiting factor. Androgen insensitivity also results in the failure of the cranial suspensory ligament to regress, meaning the testes remain in the abdomen or inguinal canal instead of the perineal region. Patients are born with female external genitalia and generally raised as females. At the time of puberty, axillary and pubic hair growth does not occur since cutaneous androgen receptors are also insensitive, and you need testosterone to develop that pubic hair. Breast development would occur despite the absence of ovaries, since aromatase in the adipose tissue will convert your androgens into estrogen. Right? They're also really short for the same reason. Remember from our last video we talked about estrogen closes epiphyseal plates. Okay, and if you have a lot of testosterone that's not working at the receptors, all of that testosterone gets converted to estrogen really, really early, and all that early estrogen closes the epiphyseal plates, leading to a very short person. Right, so this patient was 4 feet 11. Other than that, you can see LH levels are increased due to a lack of negative feedback by androgens on the androgen sensitivity pituitary. Testosterone levels will be high due to stimulation of Leydig cells of the intra-abdominal testes by increased LH levels. Okay, so there's a lot of LH, but not enough testosterone. So that's hypergonadotropic, hypogonadism. Okay, hypergonadotropic because you're releasing gonadotropic LH, but hypogonadism because your gonads are not making testosterone. So androgen insensitivity syndrome, very weird, funky, as I call it, type of question where the question starts with a daughter or a girl, but it's actually a male. And then the last question here is another one from microbiology, the last one we haven't talked about, right? We did Gardnerella vaginalis. This one up here was Candida. Okay, this one here was Candida, C. albicans. And then this one down here is Trichomonas, which is the one where you have to treat both partners, remember. 21-year-old woman comes to the physician because of a 5-day history of pain with urination and vaginal itching. She's sexually active with multiple partners and uses condoms inconsistently. Pelvic exam shows erythema of the vulva and vaginal mucosa, punctate hemorrhages on the cervix, and green-yellow malodorous discharge. A photomicrograph of the discharge is shown, and the discharge photomicrograph, I haven't even put it here because you don't even need it. Which of the following is the most likely causal organism? And the answer had to be Trichomonas vaginalis, with the green-yellow part and the punctate hemorrhages and the pain, all of that, right? These 3 questions actually do a really good job. Let me move this one out of the way, because this question in the middle is kind of inappropriate. Let's put the 3 microbiology questions together. Right, so let's move this guy up here. Okay. Right, so now these 3. So this one here was Candida albicans, and this one here was your Gardnerella vaginalis, and the last one is Trichomonas vaginalis. You can see the clear difference in presentation, not just of the bug itself, but also the patient, whether they have pain, whether they have hemorrhage, whether they have any kind of burning with urination, etc., and how malodorous it is. Right, so the description they gave in this last question down here is all you need to know about Trichomonas vaginalis. Trichomonas infection causes trichomoniasis, which manifests with vaginal pruritus, right, so very itchy, dysuria, and a strawberry cervix due to hemorrhage of the cervix, as well as a green-yellow malodorous vaginal discharge, which you all see in this patient. The presence of motile trophozoites on wet mount preparation confirms the diagnosis. And since it's motile, you need to make sure you treat both partners. Okay, so it's very important, and Sketchy Micro does a great job with this too. In fact, even the photomicrograph they show you is of the punctate hemorrhage of the cervix, and that was also a very good giveaway. So in these images right here, what you're seeing is this one down. What is this? This one is Trichomonas vaginalis. Okay, parasite. You can see the flagella. Some of them have faintly in the background. Okay, so that's your Trichomonas. This one here is your clue cell. Right, the see-through aspect of it is exactly how it's shown in Sketchy Micro too. Clue cells in bacterial vaginosis for Gardnerella vaginalis. Right, that's that. This here you can see all the strings, the pseudohyphae, right? So pseudohyphae in vulvovaginal candidiasis. Wet mount with potassium hydroxide preparation shows Candida albicans, making pseudohyphae. And then this last one, right, which looks like tiny pebbles, that's actually going to be your chlamydia. Right? We've talked about chlamydia and all of these guys when we did Sketchy Micro. I mean, not just Sketchy Micro, but we did Sketchy Micro with the microbiology videos. So now you're getting to see them again, because it's obviously very important to always be revisiting those topics. This last question here is for chlamydia. So this one says a 27-year-old woman comes to a physician for a 1-week history of painful urination and urinary frequency. No history of serious illness, doesn't take any medications. She is sexually active with her boyfriend, temperature is 98.1 Fahrenheit. No costovertebral angle tenderness. Urine dipstick shows leukocyte esterase, which is a giveaway for some kind of infection. Gram stain doesn't show any organisms. Which of the following is the most likely causal pathogen? Well, it had to be chlamydia because that's actually intracellular. Although most patients are asymptomatic, patients can present with urethritis or vulvovaginitis as seen here. Chlamydia do not gram stain well because they are obligate intracellular bacteria that lack muramic acid in their cell wall. In the diagnosis of chlamydia infection, Giemsa stain or fluorescent antibody stain can be used to identify reticulate bodies, which are cytoplasmic inclusions, and that's what you're kind of seeing in the image on the bottom right. PCR, nucleic acid amplification, is the gold standard diagnostic test for chlamydia. Okay, so very important to know both how the patient will present in all 4 of these scenarios, as well as how the bug itself looks like and its characteristics. Right, that's microbiology and the clinical reproductive aspect of being sexually active and getting infections. Okay, so that's just a touch of it. There's so much more involved with all of that from microbiology, and when we did microbiology, we've already kind of covered that. So it's always good to revise that, and if you're doing this along with me in full FA playlist, this would be now also a good day to go back and revise sexually transmitted infections within the microbiology systems section. Now, what we're seeing here are a couple of the OBGYN topics of pregnancy. Right, so pregnancy complications: abruptio placentae, morbidly adherent placenta, placenta previa, Vasa previa, postpartum hemorrhage, and an ectopic pregnancy. All of which are pretty common scenarios that occur throughout the day within the OBGYN section. So let's take a look. First one, abruptio placentae. Premature separation, partial or complete, of the placenta from the uterine wall before delivery of an infant. And you can see that, right? On the left, they're showing you complete abruption with a concealed hemorrhage, right? So the placenta is no longer attached to the mom and there's bleeding. But outside, you see nothing. Okay, so it's concealed hemorrhage. Whereas over here, you have partial abruption and the blood is coming out. And you're never supposed to really bleed while you're pregnant. It's not a normal sign. Risk factors are trauma, such as a motor vehicle accident, smoking, hypertension, preeclampsia, which is basically hypertension also, and cocaine abuse, which is also a sense of hypertension, right? Cocaine, remember, is a vasoconstrictor. Presentation is going to be abrupt, painful bleeding, either concealed or apparent, in the third trimester. It could lead to possible DIC, mediated by the tissue factor activation, which can then again cause maternal shock, and of course it will cause fetal distress. So you're going to note that the heart rate of the baby starts decelerating, life-threatening for both the mother and the fetus. Right? And this is really, really dangerous. This is really dangerous. The baby can die, the mother can die. So you got to make sure you immediately deliver as soon as possible, and then stop the bleeding as fast as possible. The next one, morbidly adherent placenta. So this is the opposite. Right? In this one, the placenta let go of the mother. Here, the placenta is holding on a little too hard. Right? You're seeing that. On the left, you're seeing normal. On the right side, you're seeing 3 different levels of how hard it can hold on. Either it's going to accreta attach, increta go into, or percreta perforate. Right? Those are your 3 different levels of attachment. Defective decidual layer. Right? You have to remember that the problem is with the decidual layer. That's an answer choice you can get. Leads to an abnormal attachment and separation after delivery. Risk factors are prior C-section or uterine surgery involving myometrium, inflammation, placenta previa, advanced maternal age, multiparity, so they've given birth many times. 3 types distinguishable by the depth of penetration. Placenta accreta attaches to the myometrium without penetrating it, and that's the most common type. And that really sucks too, because this placenta, it's not exactly penetrating the myometrium, but it's attached to it. It won't let go so easily, and when it does let go, it might cause excessive bleeding. Placenta increta is bad, much worse than the accreta. Placenta penetrates into the myometrium, so now this won't necessarily even let go, right? You might have to do extra surgery to take it out of the myometrium, and then of course repair the myometrium. And the last one is the worst, placenta percreta, where the placenta penetrates through the myometrium and into the uterine serosa, invading the entire uterine wall. Often, some of these things, if you can't repair them, you have to do a hysterectomy. Okay, can result in placental attachment to the rectum or bladder, which can then cause hematuria. Right? So this can go through all the way, and if this is the side where the bladder is, because remember your placenta is on top of the bladder, right? And if this perforation is going through on the same side where the bladder is next to it, it can go into the bladder. Presentation is often detected on ultrasound prior to delivery. No separation of placenta even after delivery, which can then lead to postpartum bleeding. Right? And this is relevant, always relevant to Sheehan syndrome, right? Which is basically death of your pituitary gland because it stopped getting blood. Right? Very common in mothers who deliver and have too much hemorrhage. The last case on this page is placenta previa, right? And I like how these are named because the previa gives you a preview, right? And it can either be a partial or complete preview of the placenta, right? That's all it is. You're getting a preview of the placenta through the cervix, right? And it's associated with previous C-section delivery. I also put that here as well. Attachment of placenta to lower uterine segment over or less than 2 centimeters from the internal cervical os. Risk factors of multiparity or prior C-sections, which is a common thing they'll tell you in the question, like the mother had 3 kids and all 3 were born with C-section. Well, now in the 4th kid, it's very likely she might end up having placenta previa. It just happens. Right? So associated with painless 3rd trimester bleeding. Painless. So if a mother comes in with painless bleeding, you want to think of this. But if a mother comes in with painful bleeding, this is painful, right? Where it ripped off. Okay, so very important. Now let's take a look at some of these questions here. So one up here, 24-year-old woman, G1P0, comes to labor and delivery triage at 28 weeks gestation due to intense abdominal pain, vaginal bleeding, and few fetal movements, which is really bad. Temperature is 98, blood pressure is super high, and exam shows a tense abdomen with tender uterus. Ultrasound shows a hematoma between the placenta and uterine wall, and no fetal cardiac activity. So what they just described is this. Right? This is a hematoma between the placenta and the fetal wall. Where was I? And no fetal cardiac activity, which basically means the baby's pretty much dead. Lab results, low hemoglobin, platelets are low, 60,000, normal liver function. Patient is hospitalized and is bleeding from her vagina, gums, and IV sites, which is a giveaway for what her symptoms are telling you. Blood is in her Foley catheter as well. What is causing her bleeding? And the answer is release of tissue factor into maternal circulation. Her bleeding is a sign of DIC, right? Because she has a dead baby inside her and a hematoma inside her uterus. DIC is a life-threatening obstetric complication, and it is mediated in pregnancy by tissue factor, thromboplastin, which is found in high concentrations in the placental trophoblast. This patient's presentation is consistent with abruptio placentae, which can result from severe hypertension, as in this patient. The abruption leads to fetal demise and caused, the abruption led to fetal demise and caused DIC, which is very common. Okay, so you have to be ready for that. Hypertension should never occur in a mother that's pregnant. Got to be careful with that stuff. And then this question down here. So you see a 36-year-old woman, G3P2, at 31 weeks gestation, comes to the emergency department because of painless, bright red vaginal bleeding for 1 day. It's painless, right, which is a giveaway that it's not placental abruption. So what else could it be? Well, the only other thing we saw just now was placenta previa, right? That one had painless bleeding. She has not felt any contractions. Her other children were delivered by C-section, which is, again, a giveaway for placenta previa because of their breech position. Fetal heart rate is reactive with no deceleration. So the fetus is working fine, right? The fetus has a good heart rate, no decelerations. Everything is okay. It's just she's got some, unnecessary painless bleeding. And the bleeding is occurring because the placenta is right there, right? There's no wall right here, right? This portion is not covered, right? Look, the normal placenta is supposed to be covered entirely by the wall it's attached to. But if the placenta is over here, it's not covered at the part of the cervical os and you're bleeding from it. So which of the following findings is most likely on ultrasound? Placenta over the cervical os, right? Placenta previa. Placenta over the cervical os is characteristic of placenta previa, which classically presents with sudden painless vaginal bleeding in the 3rd trimester without fetal distress, as seen in this patient. Well, I should really make the without red too, because that's the main thing. There's no fetal distress, okay? Without fetal distress. As seen in this patient, 3%, what is 3%? 30% equals visualization of, this was definitely, I'm pretty sure this was 30% of people that chose this wrong answer. Oh, no, you're right. Or I already had it right. 85% chose the correct answer. So it was an easy question to get right? Because it's not placental abruption. They gave you the giveaways, which is C-section, previous C-sections, and painless bleeding. 3% chose visualization of membranous umbilical vessels near the cervical os, but that's characteristic of Vasa previa due to filamentous cord insertion. We're going to see that on the next page. Vasa previa would be a whole different scenario. This condition can also present with painless vaginal bleeding if the unprotected fetal vessels rupture. Bleeding from Vasa previa is usually accompanied by fetal distress, though, because the baby is the one that's bleeding out, right? That blood vessel is for the baby. So that one is it's very different. This is how you would differentiate between Vasa previa and placenta previa. So this is just an image showing you more of the same stuff: accreta, increta, and percreta, right? Where the percreta can again go through and attach to another organ, whatever's behind it. But next page goes on to Vasa previa, right? So now this one is different because now here you also get, you know, painless bleeding, but there's the fetus can die because the thing that's actually bleeding is the fetus, right? So here what happens in Vasa previa is fetal vessels are the ones that are running over or in close proximity to the cervical os, right? So you can see instead of the placenta being in the cervical os, now the blood vessel is, right? But the placenta is in an okay place on either side, so that's not really relevant. They go on to tell you that it may result in vessel rupture, exsanguination, which basically means bleeding out to death, and then fetal death. Presents with triad of membrane rupture, painless vaginal bleeding, and a fetal bradycardia. Right? Remember that the fetus has a super high heart rate, above 110. And if it starts going down, that's deceleration of the fetal heart rate, and that's a sign that the baby's dying. Emergency C-section is usually indicated to save the baby, frequently associated with velamentous umbilical cord insertion. Cord inserts into the chorioamniotic membrane rather than the placenta, right? And that's the velamentous umbilical cord insertion. If the cord inserts into the chorioamniotic membrane instead, fetal vessels will travel to the placenta unprotected by the Wharton jelly, right? And that's kind of what you're seeing here. On the left side, you can see velamentous attachment. This umbilical cord is going around here, inserting into the placenta, right? And that's not so good. Okay, even here you have two things. You have a succinturate lobe of the placenta, and then another placenta there, and a bunch of vessels passing under. All of that is very unsafe, right? So that's your Vasa previa. Okay, and another image here. This one basically shows you that the placenta is no longer placenta previa, right? This placenta is here, but you can see how this is coming out and going through the cervical os area, right? Trifurcated umbilical cord, right? And your velamentous cord insertion. Okay, so this cord coming out here and going like that is not safe. It's not protected by the Wharton jelly. So that can lead to bleeding of the baby. All right. One more thing I wanted to just point out before I keep moving on is that they mention, where is it? This one says inflammation. Here they just mentioned trauma. There was something I wanted to say. Okay, we'll probably see it in one of the questions eventually. Because a lot of these things, yeah, risk factors are very high yield because risk factors are what you're going to see in your question, right? Your patient is going to present with these risk factors, which you're supposed to be able to equate to a pathology. Like with placenta previa, the risk factor was previous C-sections, right? If they've had C-sections and now they come with painless bleeding, but the fetus is doing okay, that's placenta previa. If you have painless bleeding and the fetus is not doing okay, that means that the fetus is bleeding. That's Vasa previa. Right? So that's basically, it's just something to watch out for. Whenever you decide to study this more closely, make sure you pay attention to what are the risk factors that can lead to this stuff. Oh, this is what I wanted to point out. Uterine surgery. So later on, we're going to see a question, right, where a patient got uterine surgery and then now has morbidly adherent placenta. And you were supposed to think of that just because her history. They'll tell you in the question that the history of the patient has some kind of uterine surgery. You got to be ready with that, right? So don't overlook the risk factors. Risk factors are very important. Now the last two things, postpartum hemorrhage and then ectopic pregnancy. Postpartum hemorrhage is due to the 4 T's, right? Tone, uterine atony, which is the most common thing. So no tone, which means that the contraction is no longer closing out and you keep bleeding. Trauma, such as lacerations, incision, or some kind of uterine rupture. Thrombin, because of coagulopathy, or tissue, right? Mainly tissue factor if you have retained products of conception, which might lead to DIC. Right, so postpartum hemorrhage, and then keep in mind all the relevant things like Sheehan syndrome, maternal death, etc., etc. The last thing here, ectopic pregnancy. This one is also heavily related to surgery, right? Salpingitis, as well as history of prior tubal surgery, right? So this one, very interesting concept. I saw a question where a mother had gotten tubal ligation, right? She got tubal ligation, and now you would think she's not going to get pregnant, but somehow she ended up getting an ectopic pregnancy, right? And in that question, we're going to see that question too as I keep going. In that question, it's like you really couldn't pick any other answer choice. You're not going to pick appendicitis because the way the question was presenting. There's no guarding. And they'll tell you stuff. They'll tell you stuff that really points at an ectopic pregnancy. So like a slight increase in ACG. So what happens in ectopic pregnancy is implantation of the fertilized ovum in a site other than the uterus, most often in the ampulla of the fallopian tube, right? And you don't want implantation in the ampulla of the fallopian tube. Suspect with history of amenorrhea, lower than expected rise in ACG based on the dates, and sudden lower abdominal pain, confirmed with ultrasound, often clinically mistaken for appendicitis, because there will be one-sided pain. Right now, appendicitis is always on the right, but if it's sudden pain on the left side, it's because it's on the left fallopian tube. All right, and a patient with tubal ligation can also have such an issue, so you got to be ready with that. The last thing on this page, before we look at our last few questions for this video, are amniotic fluid abnormalities, which we did discuss when we were doing neurology, right? Because in neurology, polyhydramnios and oligohydramnios were pretty important. It was also discussed when we did renal, because oligohydramnios was very important in renal stuff. So polyhydramnios is too much amniotic fluid, where oligohydramnios is too little amniotic fluid. In polyhydramnios, which is often idiopathic, meaning that it just occurs for no fucking reason, polyhydramnios is often associated with fetal malformations like esophageal duodenal atresia and encephaly, both resulting in an inability to swallow amniotic fluid. Right, so maternal diabetes, fetal anemia, and multiple gestations. These are the key things you want to watch out for when you have too much amniotic fluid. Right, this UWorld table is pretty much summarizing the same stuff. Right, any of these things can cause impaired fetal swallowing, leading to polyhydramnios. Right, these things. Or any of these things can lead to increased fetal urination, which would also cause polyhydramnios. Right? So two different ways to get polyhydramnios: impaired swallowing or increased fetal urination. Right? And both of those are issues that can, well, both of these are issues, right? Fetal malformations like esophageal or duodenal atresia or anencephaly are issues that can cause polyhydramnios. So polyhydramnios causes many symptoms because polyhydramnios basically squeezes the baby. So you're gonna note things like club feet and facial, messed up facial features, stuff like that. Oligohydramnios is associated with placental insufficiency, bilateral renal agenesis, which is why we talked about it in renal, posterior urethral valves in males, and resultant inability to excrete urine. Any profound oligohydramnios can cause Potter sequence, which was discussed in renal. So very important stuff. Let's take a look at some questions and then we'll be done with this video. UWorld. So 32-year-old woman at 28 weeks gestation has an ultrasound that shows markedly elevated amniotic fluid levels. So that's polyhydramnios. She has been feeling short of breath when she's supine, but has no other symptoms. She has a history of epilepsy that is well controlled with medication, which is a huge exclamation mark right there, right? Because she's taking some medication for epilepsy, and if you recall from neuro, a lot of those anti-epileptic medications were not safe to take during pregnancy. She does not use tobacco, alcohol, or drugs, and her immunizations are up to date, and she has no allergies. Physical exam shows an abdominal circumference that is larger than expected for gestational age because of the polyhydramnios. What fetal anomaly most likely accounted for the polyhydramnios? And that, you pick any answer choice that works, and it was anencephaly here. Anencephaly. Why anencephaly? Polyhydramnios can be due to decreased fetal swallowing or increased total urination. Fetal anomalies with impaired swallowing include things above, such as GIT obstruction and anencephaly from cranial neurotube defects. Causes of increased fetal urination include high cardiac output due to anemia or twin-to-twin transfusion syndrome. Maternal diabetes and multiple gestations tend to cause milder polyhydramnios than the aforementioned fetal anomalies. This patient's prenatal use of anti-epileptic therapy is a substantial risk for fetal neurotube defects such as anencephaly. So you had to make that connection based off of something they presented in the question as if it was no big deal. They just said, she has a history of epilepsy, but it's controlled with medication, so don't worry about it. Right? And then you keep going. But that's not how you're supposed to read that. You see someone is taking a medication, that's a big deal. Right? So she has a history of epilepsy that she takes a medication for, and that medication might be affecting the fetus because she is pregnant, and you know this. Right? Next question, 28-year-old woman, G3P3, comes to the emergency department with severe abdominal pain in the lower left quadrant and vaginal bleeding. She's saturating a pad every 3 to 4 hours, and that's a lot of bleeding. Past surgical history shows 3 cesarean deliveries and permanent sterilization via bilateral tubal ligation. A urine pregnancy test is positive, and ultrasound shows a 2 centimeter mass in the left adnexa adjacent to the ovary and a thickened endometrial stripe. What would be expected on a uterine curettage? And you would expect dilated, coiled endometrial glands and edematous stroma. Very, very healthy looking endometrium, because she has an ectopic pregnancy and her body's getting ready. And so this question is a UWorld type of question where they gave you way too much. They literally spelled out the diagnosis for you. Pregnancy test is positive. Ultrasound shows a mass in the left adnexa. She has pain in the left lower quadrant. Vaginal bleeding. Right? 3 cesarean deliveries and tubal ligation that's been done before. All of this comes together to tell you that she's gotten a lot of stuff and a lot of injury in her uterus and fallopian area, and anything can happen. Right? But she's definitely pregnant because pregnancy test is positive. And this is not a cancer. This is not a type of cancer that's causing her issue. So, at that point, you just pick a very healthy looking endometrium that's ready for implantation, and that would be this one. Dilated with many coiled endometrial glands. You would even see vacuoles, right? A lot of spiral arteries, etc., etc. And that's all due to her tubal ligation. So that's related to the thing we just looked at right here, right? Ectopic pregnancy with a history of prior tubal surgery. Okay. So prior tubal surgery also is related to prior ectopic pregnancy because this probably required a prior tubal surgery. Last 3 over here. So 35-year-old woman, G2P1, comes to the office for a routine prenatal visit. Her first child was born with a hydrocele and syndactyly of the first and second toes. The patient has no significant medical problems and takes no medications except for a multivitamin. Examination reveals clear lungs and normal first and second heart sounds. The abdomen is soft and non-tender. Uterine size, fetal movements, and fetal cardiac activity are all within normal limits. Oh yeah, I'll definitely. I had to make some corrections to that, but I'll definitely do that. The patient undergoes amniocentesis during the 18th week of pregnancy. Amniotic fluid analysis shows an increased level of acetylcholine esterase, which is a giveaway for a specific diagnosis. Acetylcholine esterase is high. That's because it's leaking out. The patient's amniocentesis results most likely suggest which of the following processes, failure of which of the following processes, and it's a failure of fusion of the edges of the neural plate. Failure of the rostral neuropore to close results in anencephaly, whereas impaired closure of the caudal neuropore results in spina bifida. If either fail to fuse, an opening persists and allows leakage of alpha-fetoprotein and acetylcholinesterase into the amniotic fluid. Right, so that would be a good time to go back to the early parts of neurology and take a quick look at neuropore and neural tube defects. 6-hour-old boy is in the newborn nursery with feeding difficulties. The patient was born at 39 weeks gestation to a 33-year-old prima gravida via cesarean delivery due to failure to progress and late deceleration seen on fetal heart tracing. Okay, so a couple things are going wrong here. APGAR scores are 8 and 9, but exam shows an infant with excessive drooling and occasional coughing. So right there, you should be able to figure out what's going on. We saw some of this being explained in the GIT embryology section. Right, cardiac, respiratory, and abdominal exam are otherwise normal at rest. That's because it's a GIT problem. When the infant attempts to be breastfed, several bouts of coughing and perioral cyanosis develop with oxygen saturation of 85% on room air. That's because when you're feeding him some shit, it's going into his throat. It's going into his actual respiratory path. What is the most likely cause of his condition? And it's a failure of the primitive foregut to separate from the airway, aka he has a tracheoesophageal fistula with esophageal atresia. Right? That's exactly how that presents. And keep in mind though, like I said, this is a UWorld type question. These are UWorld questions. UWorld questions give you too much information. They literally spell out the diagnosis for you over and over and over and then smack you with like 5 answer choices where one is very blatantly obvious. The only reason you get questions wrong in UWorld for the most part is because you haven't finished studying. Right? Once you finish studying, you know exactly what the answer is for all of these questions, except for the very, very high-end difficult type questions. Most of these questions spell out too much. So if this same question was presenting on NBME, they wouldn't give you half of the shit that's in this question. right? They wouldn't tell you the APGAR scores. They wouldn't tell you cardiac, respiratory, and abdominal exam are okay. They would literally just tell you this: an infant is born, and when it's breastfed, it coughs and has perioral cyanosis with an oxygen saturation of 85%. What's the most likely cause of condition? That's all they'll tell you. An infant is born, we fed it, he coughed, has cyanosis now. What the fuck is wrong, right? And that's it. They don't give you so much stuff. So doing UWorld is a hard way to prepare for NBME. But if you are preparing for NBME, just look at all the NBMEs you can back to back, or watch my NBME review playlist. You'll get to see how to think and how to approach topics based off of minimal information. Okay, and get used to that. When you're studying UWorld, understand that not everything that was given to you in that question needs to be given to you for you to get the correct answer. Okay, so this wasn't so bad at all. Last question for this video. A 1-hour-old boy is in the neonatal ICU with tachypnea and hypoxia. The infant was born at 39 weeks gestation via cesarean delivery due to variable decelerations. The pregnancy was complicated by a lack of prenatal care. The infant weighs 7 pounds 1 ounce. Physical exam shows a flattened nose and bilateral club feet. Right? And as soon as you think of that, right, flattened nose and bilateral club feet, what could possibly cause that? That's a sign of polyhydramnios. There was too much fluid and it was squeezing on the baby, right? Because you're stuck inside the placenta, you're a fetus inside the placenta, not inside the placenta, inside the womb. And while you're inside the womb, if there's way too much fluid in there, it's squeezing on the baby. It's squeezing on the baby's face, it's squeezing on the baby's toes, fingers, everything. And that's why this baby has a flattened nose and bilateral club feet. The feet are messed up too. Breath sounds are markedly diminished. Why? Because the baby wasn't able to swallow enough of the fluid to develop the lungs. Right? The infant is intubated and mechanically ventilated, but oxygen levels don't improve, and then the infant just dies 1 hour later. What is the most likely to be found during autopsy? Any answer choice that would lead to polyhydramnios, and the correct answer for this baby was renal agenesis. The infant has features consistent with Potter sequence, such as pulmonary hyperplasia, along with facial and lower limb deformities. The renal anomaly leads to decreased urine output by the fetus, classically see bilateral renal agenesis. Since the volume of amniotic fluid depends on the fetal urine production, affected infants have severely reduced or absent amniotic fluid, right? And this is a case of oligohydramnios here. The lack of amniotic fluid causes external compression of the face and lower extremities. Compression of the umbilical cord leads to fetal heart rate anomalies, right? Because what they're describing here is that the oligohydramnios is not cushioning the baby, right? So now the baby is being squeezed down by the whole surrounding that the baby has, and everything gets messed up, right? So be very ready for stuff like that. This is polyhydramnios related stuff. This last question was actually oligohydramnios related stuff, where as they described, I think I said it the other way around, but as they described, without all the extra fluid around, without all the actual amniotic fluid, there was no cushioning for the baby to develop inside of, so the baby's being squeezed by everything around it within the womb, right? And that's your Potter sequence stuff. So again, reproductive and respiratory, although I get that the first aid is in ABCD order, it just so happens that the way it's all written is the perfect order to study it in, because it makes it easy for you to go back and review shit. So in reproductive right now, we've been seeing a lot of renal stuff. We've been seeing a lot of endocrine stuff. Right? You want to make sure you go back and study those again if you forgot it. If you forgot Potter sequence, go back and take a look at it again. Look up all the things that were related to oligohydramnios and polyhydramnios, right? And make sure you understand neurotube defects, because that development, we talked about it when we did the reproductive embryo videos and combined it with Kaplan, that development is very critical. So be very careful with that, right? And the differences between poly and oligohydramnios are very, very key, because you're going to get that a lot in your questions, right? So that's good stuff. We did a lot of practice questions here. I hope you guys understood a lot of the stuff that we're talking about. And then in the next video, we'll start moving on to hydatidform moles.